Okay, we're going to go ahead and get started. Good afternoon, everybody. I just want to thank everyone for taking the time to join us today for the Missouri COVID-19 vaccinator call. It's March 2nd. We have a lot of updates today to go through. I do want to remind everyone that we do record these calls, and I'll make that available on our vaccinator resource page by tomorrow morning if you have any colleagues that weren't able to join. Also, it may look a little bit different today. We are using a different version of WebEx, so I just wanted to make note of that in case you're wondering why it looks a little bit different in this meeting today. The goal is to use this form, which would allow us to make a recurring meeting. If you're anything like me, if somebody doesn't put something on my calendar and it's not set there week after week, it's difficult sometimes to remember to replace that and use a new link each time. So the goal would be to have a recurring meeting set up for all of you with the same link each week, and this version will allow us to do that as long as it works okay for us today. So that's the reason for the change, and hopefully then starting next week we'll have one single link that you'll use for the remainder of these vaccinator webinars. So without further ado, I'm going to bring Ted Delicasse on, and Brad, you can go ahead and advance to the next slide, and Ted is going to walk us through our objectives today.
Wonderful. Lisa, can you hear me, ma'am?
Yep.
Awesome. Everyone, thanks so much for being here today. Welcome to March, and we have quite a bit to cover, as Lisa called out. So I'm going to jump right in, and we're going to move into that first bullet you see there, line of sight. And so, Brad, as we go to that next slide, I just want to call out for folks, as we jump in here, please hold all your questions to the end. Feel free to put them in the chat. Since we do have so much to cover, we're not going to chunk this out. We're going to explain because it follows a narrative. And then on the back end of this vaccine line of sight update, and then the J&J deep dive, then we'll jump into the questions. So that is in no way discouraging conversation. Just to let you know, we want to present as a full narrative, and then we will invite all of that conversation on the back end. So Brad, please go to that next slide. And as we do, you all have probably become pretty used to this slide. What we thought at the beginning of this week is a little bit different now. We thought we were going to present you this slide and explain, hey, we've had about 120,000 give or take average vaccine for the last 3 or 4 weeks. And we have been told and promised J&J is going to change that. Well, the reality is a little bit different. So as we go to that next slide, Brad, I hope everybody can hold that 120,000 in their head. So as you probably have heard, J&J, their EUA was approved, and 50,000 vaccine did find its way into Missouri. However, a couple of things also happened. We were informed late last night that we will not receive any more Johnson & Johnson vaccine until the last week of March, so that week of the 29th. So that means that 50,000 that we got is all we are going to have through the end of March. As you can see here, we allocated 37,000 of those doses across all delivery channels. I'm going to save describing and detailing too much about the Johnson & Johnson vaccine until my colleague Lana speaks more to that later. However, it is agnostic to any delivery channel and also can serve a diverse set of populations. I know we're hearing a lot of narratives bubbling up around Johnson & Johnson, and I encourage you to keep an open mind and turn your attention to my colleague Lana a little bit later in this brief. So the final punctuation of this slide, you'll see at the bottom there, we're going to use the remaining 12,500 or so Johnson & Johnson to peg against the targeted teams that have been working in our dense urban areas, as well as to go towards some of those mass events. The thinking here is that Johnson & Johnson is applicable and can be used for the broad population that is currently eligible, and that prevents us from having to do a booster event mass vaccination. So the state strategy moving forward, you will see more about that coming in the next 2 weeks, talking about the principles that we will be using to deploy Johnson & Johnson. So that's the unideal update on Johnson & Johnson, and here's how it changes how we will approach the rest of March. So as we go to slide 6 here, knowing that we are just working with 120,000 vaccines, we are not going to let that deter us from what the governor announced last week in activating tier 3 of phase 1B. And to give you a sense of what that population looks like, that's about 550,000 eligible Missourians who will be added to the overall eligible population of phase 1A through phase 1B tier 2. Said another way, that means that's 550,000 eligible Missourians that are not captured somewhere else in phase 1A through phase 1B tier 2. So those are unique individuals who will be eligible come Monday, March 15th to receive vaccine. I'm going to be pretty specific about what that means in terms of vaccinating those individuals. What that means is that in each delivery channel, just like every other eligible population, we encourage those tier 3 critical infrastructure folks to seek out, and you will see what the delivery channels are, to seek out vaccine from the existing delivery channels. And so employers that are interested, and we realize that there are some employers that are quite large and want to do what they might call in-house vaccinating on site, we encourage that, and we ask that you submit that through the all other community providers come next week when you are eligible to start submitting for vaccine the week of Monday, March 15th. What I will call out here, and you will see in later slides, is that it is a very constrained amount of supply that falls in that all other community providers. Said another way, folks, tier 3 is now lumped into all the other eligible populations, and the delivery channels will receive increases in supply, but they will not receive more vaccine just for the tier 3 population. No other population has received that kind of treatment. And so it is incumbent on those delivery channels to have those discussions if they would like to focus on tier 3 populations. And I know there will be some questions about that, so we will come to that later, and happy to have more discussion there. So if we're recapping real quick, no more J&J until the end of March. That means we're working with 120,000 weekly vaccines spread across Pfizer and Moderna. We still have tier 3 that's coming online and eligible on Monday, March 15th. And as we move into the next slide, that brings us to our next update, and that is we are bringing in pharmacies to be a dedicated delivery channel. And so if you'll recall, early in our focus, the federal government offered us the opportunity to bring Walgreens and CVS on as pharmacy partners to vaccinate all the long-term care facilities in Missouri. And we jumped at that as an opportunity to vaccinate some of the most vulnerable and some of the most in need in phase 1A. Now, what we are seeing is as we move towards tier 3 activation, we get towards the more broader public, pharmacies will become a more regular approach and delivery channel to getting vaccine to communities. So as you'll see there in those last two buckets, we are formalizing pharmacies, and they will start receiving vaccination the next week, because pharmacies are connected at the hip with many communities around the state. Local pharmacies are an integral part to delivering vaccine in an equitable and efficient way. And the Missouri Pharmacy Association has stepped up as a coordinating resource to coordinate total amounts of vaccines across regions to help bring some order to that process. And so just a brief call out here, which I'm sure will be a question later. If you recall, all other community providers, a strong and majority subset of that group was formerly pharmacies. We are now asking pharmacies to work with the Missouri Pharmacy Association to coordinate amongst themselves across regions. That brings order and consistency to pharmacies so they know how much they can receive. Primarily, they will be receiving Moderna from that allocation. Again, encourage folks to reach out to the Missouri Pharmacy Association for more information about that. And so as we go to the next slide, you will see how all of these changes are coming together. So the slide before you, you have seen before. The only change is the added pharmacies delivery channel. You can see that we are using the approximate numbers of 120,000 vaccines. That will be the amount of vaccine that we can expect, give or take, through March. And as you can see here, we are providing these allocations for next week, so the week of the 8th of March and the week of the 15th. So that gives all the delivery channels here the consistency they need for the next coming 2 weeks. So the week of the 8th and the week of 15 March. Starting the week of 22 March, we're going to change how we have been allocating vaccine. To be specific, that means we are going to start allocating against populations against unvaccinated eligible populations per region. So to date, we've been doing general populations. And if you recall, Region A has about 23% of Missouri citizens. And when we've been saying that, what we've been saying is total citizens. The shift starting the week of 22 March will be the numbers we will be looking at will reflect unvaccinated eligible populations. So phase 1A, phase 1B through tier 3, those populations that have yet to receive a vaccine. And we flag this now to go live the week of 22 March because we realize on the state side, you all need consistency in order to plan. And so we're going to work with each delivery channel up here so that you can better understand what that change will look like and mean for your region. And that's what the next slide speaks to. So to date, as you can look on the left, we've been using total overall population, and that has served us well. It has served us operationally in that it has tested and proven that if we pushed vaccine in proportion to the overall population, meaning the absolute highest that a particular region may get, that they could withstand that and they could use it. And all of those regions proved that's possible. And from a state standpoint, we wanted to make sure that everybody in the state, from communities in the north, south, east, and west, saw the effects and the life-changing effects of vaccine. So now that we have systems in place, we've proven the operational models, that's where we're shifting to this right side of the slide. And that is moving forward, starting the week of 22 March, we're going to be looking at eligible population. And again, I'll define eligible population for everybody here. We will be looking on a weekly basis in each region, what is the total unvaccinated eligible population? And so what that means is we can start using data to be more specific and targeted about where we're pushing vaccine. So if we're seeing great strides in one region and other regions are lagging behind of unvaccinated eligible population, we can respond in proportion to the changes that we're seeing. So I know this is a bit of a change. Hopefully everybody can see the logic that we're working with. And I'll call out that last bullet on the right there, that the only way do we get to the next phases and tiers in this plan is if we vaccinate the current eligible populations. So that's why moving from overall to unvaccinated eligible makes sense. And again, you will have ample opportunity to speak with your state sponsors to understand how that will affect allocation. We are not springing this on you. It doesn't go effect till 22 March. The numbers that you can expect that you have been using as your planning assumptions will stay in place for next week, the week of the 8th of March and the week of 15 March. So as we go to the next slide, I know there's plenty that has been covered today and everyone's always very interested in this slide. So I just want to quickly recap. No more J&J, as you see reflected in that far right column, until the last week of March. We are introducing a new pharmacy dedicated delivery channel. We will be shifting to an unvaccinated eligible population organization model come the week of 22 March. You will be hearing plenty more about that. It will not be a surprise, and you will have insight into what you can expect come the week of 22 March. What you can expect over the next 3 weeks is reflected right here. And we are expecting to see slight increases of Pfizer each week. The reason that you don't see that reflected here is it is a safe planning assumption that at minimum, we as a state will receive 120,000 doses. So from there, anything else over that is a positive, and we are using the data we are receiving from our partnership with Deloitte to push that additional vaccine into the counties where we are seeing the data show us the lowest number of vaccinated citizens with the most acute needs. And you will start seeing more of that data in these calls in the future. So plan on having some of that Deloitte data make its way into this group and to this briefing next week. As you can see, one call out I do want to make for LPHAs and FQHCs, while they are only pegged to receive 11,000 doses for each of their delivery channels, over the last 3 weeks, they have seen particular counties where the data has shown that is in need of vaccine. We have pushed to LPHAs and FQHCs specifically. So that 11,000, again, I stress, is just a baseline, and we use data and additional doses to push more into those counties, those LPHAs and FQHCs specifically, to serve those communities most in need. A couple of call outs on Moderna. The new pharmacy chain, pharmacy distribution channel will use primarily Moderna. I did call out as Tier 3 becomes live and active on March 15th. If you are an employer and you are looking to submit plans, you will hear more about that from my colleague Shad and Director Dixon of DED later this week. So if you are confused about that process, I encourage you to be on one of those town halls they are having, and we will be sure to put that information out for you. So I believe, if I'm not wrong, Brad, if we can go to the next slide and I make sure this is the last one. Okay, wonderful. Again, folks, please continue to keep those questions coming into the chat. We will address them at the end. I want to continue this momentum, though, so that my colleague Lana can share her expertise, and then we will circle back to all of your questions. And while she is going, I will look at many of them so I can have answers ready and so that we can have as much dialogue as possible. So thank you very much. And Lana, I will turn it over to you for the J&J deep dive.
Thank you. Okay, so the next slide, please. So a basic overview of the Johnson vaccine is, it is actually a one-dose vaccine. It is based off of an adenovirus. It is not the mRNA vaccine like Pfizer or Moderna. The good news is it is stable for at refrigerated temperatures at 2 to 8 degrees Celsius or 36 to 46 degrees Fahrenheit for up to 3 months, as long as the vials remain unpunctured. The minimum dose is 100, but that's actually 2 boxes of 50. And there's 5 doses per vial at this time. It's approved for, it received approval for anyone 18 years or older, and we have added the EUA fact sheets on the website for you. A good news is they've also looked at if an individual is unable to complete the mRNA vaccine series, they are eligible to receive a single dose of J&J vaccine, and they are complete after that. Next slide. We wanted to talk a little bit about efficacy because there's a lot of concerns about this. Some people have expressed lots of concerns. The efficacy that was shown to the Advisory Committee on Immunization Practices was actually very, very good. It was actually pretty high at preventing severe illness and even death or hospitalizations due to COVID. Some people said, well, it's not as good as the Pfizer or the Moderna. The reason is they were not compared at the same time. They took on different dates in different countries. So where Moderna and Pfizer were trialed at besides the U.S., the J&J vaccine was trialed in the U.S., but in other countries as well, but not particularly the same countries that Moderna or Pfizer were trialed in. So that explains a little bit in the efficacy change. However, they were really impressed with the efficacy the vaccine showed. Next slide. So for you all information, it does ship at a refrigerated state, which is a change from Moderna and Pfizer. So upon arrival, make sure it's kept in the boxes for the vaccine, and you just put it in the refrigerator. You cannot place it in the vaccine in the freezer because that will destroy the vaccine since it was already out of the freezer. Again, the good news is you can store them for up to 3 months in a refrigerator. So this works really well for those providers that say they want some vaccine, but they don't have a lot of patients that come in routinely. It's really good to hit this one. This is a great vaccine for this purpose because you can store smaller quantities. You can split that 100 doses up between you and another clinic. So, and then hopefully within 3 months, you'll be able to vaccinate 50 individuals. There is one caveat. Once you start puncturing the vaccine vial, you can puncture it and store it in the vaccine refrigerator for about 6 hours, but it has to be refrigerated. If you store it at room temperature, punctured, it's 2 hours. You use it or you lose it. That being said, no vaccine should be at room temperature for a long time. If you're holding clinics and you're trying to go through them fast, we encourage you to use vaccine coolers if you are using at an outside clinic, and only take what you need. Next slide. So preparing the vaccine, you remove the vial from the refrigerator. Make sure you're inspecting that vial. It should be clear to slightly yellow opalescent in color. There should be no particulate. It should not be brown in color or black. If that is the issue, do not use it. Remove your cap. Date, just like you do with the Pfizer and Moderna, date and put the date and time on the vaccine vial that you've punctured it. Gently swirl the vaccine before each dose is withdrawn the same way that you would do with the Moderna vaccine. And the dose is 0.5 milliliters. Next slide. Make sure in the syringe you're inspecting it. Make sure you're tightening that syringe, the hub of the needle and the syringe together. Just a quick reminder. Administer it intramuscularly in the deltoid or the vastus lateralis of the thigh and observe the patient still for 15 minutes following vaccination. Next slide. Who should not receive the vaccine? The vaccine is only approved for those 18 years and older. So if they're under 18, they do not get this vaccine at this time. We also have a list of ingredients for you, and it's on the FDA website. But if they're allergic to those ingredients, they should not get the vaccine. And this vaccine does have that polysorbate in it, just like the Pfizer and the Moderna. Next slide. Basically, side effects were really non-pain, and at the injection site, I always tell people, well, it is a needle going into your arm. It's going to hurt. There could be some redness or swelling. The systemic side effects were headache, fever, but actually they didn't have a lot of fever with this vaccine, so it happens very rarely. Nausea, malaise, and headache. There was a history of some other adverse events that came up during the trials, venous thrombolytic events, and that is usually that they had a predisposing medical condition or a history of the DVTs. Some people, I think 4 had the venous thrombolytic events. 3 had convulsions, but those were usually associated with a history of epilepsy. 2 people experienced tinnitus. 1 person experienced Guillain-Barré syndrome. 1 person had Bell's palsy, and 2 people had peripheral neuropathy. Next slide. So precautions. And we always say it's just like any other vaccine. Some people, they can get it, but you want to use your best judgment at the time. And a lot of this follows along the same lines as our Moderna or our COVID, Moderna and Pfizer vaccines. So one good thing is if an individual is unable to receive the mRNA vaccine or complete that series, they can receive the J&J vaccine as long as you monitor them closely following vaccination. Also, the same as Moderna or Pfizer, if they're sick with COVID, they ask that you defer vaccination until that person is asymptomatic and the criteria have been met to end isolation. You should also be deferring vaccination for 90 days after antibody treatment for COVID-19. And one of the things that did not make it on the slide was co-administration with vaccines. Just like Moderna and Pfizer, they are suggesting that you wait 14 days for administering a vaccine after they've gotten the vaccine. Wait 14 days, administer this J&J vaccine, and then if you have another vaccine, you should wait another 14 days. Next slide. One thing the CDC did ask us, and they did send us a reminder at all enrolled providers, please, please, please do not charge the patient. No out-of-pocket patient goes to the patient. You cannot deny anyone vaccination based on their recipient's coverage or network status. If they show up to your facility, you will need to vaccinate them. You may not charge an office visit or other fee if this is the sole medical service provided. So, and a lot of this those are all barriers to vaccination. We really, really want to make sure that people who want the vaccine can get it and move on. We have put some reimbursement issues on the slides, and the copies will be provided for you, I do believe, or you'll have access to copies. And I think that's all my slides. Is there any more? Next slide. Okay, that is it.
Thank you, Lana and Ted. Appreciate that. Ted has been answering tons of questions in the chat. So if you haven't been looking in the chat, please turn your attention over to that. Lots of questions and answers happening over there. I'm going to look at some of the specific J&J questions that we received that I don't believe have been answered or maybe need clarification, Lana. The first one, when you said if someone is unable to complete the 2-dose series, they can get 1 dose of J&J. Did you mean if they have had 1 dose of Moderna or Pfizer but could not get their 2nd dose, should they get the J&J?
Yes, they can. It doesn't complete an mRNA series, but it is considered a valid dose and no other doses are needed. So if they can't get it due to an allergy, they miss their chance and J&J is there, you can go ahead and hit them with the vaccine and they're covered and no further doses are needed.
Great. And then for those patients who missed their 2nd dose, I think I'm about to repeat myself actually with the same question. For the patients who have missed their 2nd dose of Pfizer and Moderna, should we offer them J&J in the future when we have the issue of mismatched supplies of prime and booster?
That is an option. It is always best to complete a vaccine series for best efficacy with what the brand they got in the beginning. But however, if you do not have any other options, you can go ahead and do that.
Okay, thanks, Lana. I think that's all we've received, I believe, for as far as J&J questions. Okay. For now, going back to some questions pertaining to Ted's presentation, and I believe Adam's on with us now too. There were some questions about just site selection for the J&J vaccines being received this week. Ted or Adam, did you want to touch on that?
I'm happy to jump in, and then Adam can come in behind. He usually has to juggle a couple of calls at a time. So in short, the J&J is backed by the Deloitte data, which shows us county breakdowns of who's receiving how much vaccine and importantly, who is not. Like I said, we are working on putting that into a form that is presentable for here. It's a lot of data, and so it's not us withholding, it's us trying to figure out how we present that in a way that's digestible to everybody. So data backed, and then historical asks of vaccine that had gone unfulfilled as well. So both of those in tandem, which is an imperfect process. And so highly encourage folks to start thinking about their role and how they could maybe use J&J when it becomes available again at the end of March.
Thank you. Cindy says, and I believe she's a high throughput health center representative, since we're talking about future dates, is it safe to start planning vaccine clinics for April for the high throughput sites?
Yep, and I responded in brief there, and it's a great question, and it gets back, Brad, I apologize. I always know when someone's doing the slides for you, it's really annoying to have to go back. Could you go back to the slide, Brad, that shows the allocations through the next 2 weeks of March by delivery channel? And as he does that, folks, I just want to call out, so what Cindy's getting at, right, is there is an absolute need to provide you all with some form of consistency to understand how many, we'll keep going back a little bit more so that folks can see a little bit more. There it is, perfect. Thanks so much, Brad. So Cindy's asking, hey, if I'm a high throughput healthcare, can I expect to receive the amount of doses that are here in April? And the short answer is you can expect to receive, I would say probably anywhere between 50 to 100% of what you're seeing here. And the reason that I give that range is because these are reflective of overall population. We are going to work over the next 2 weeks to change all allocation to reflect unvaccinated eligible populations. So that is a longer answer than I think Cindy probably wanted, but it's necessary for everybody to understand that these delivery channels aren't going anywhere. Their allocations will change somewhat. And again, they're changing to reflect unvaccinated eligible populations. And to be very specific about that, those are the people that need the vaccine. And so that's how we believe, when we're being fair and equitable, how allocations should reflect, because it becomes general and imprecise if we're just sending vaccines based on overall population. So hope, even if that maybe does not satisfy some folks, hope they can understand the logic and where we're going with that.
Ted, hopefully the chat box did not break on us this time. I think we've addressed all the questions that have come in so far. So please feel free to chime in if you still have a question, or if we, for some reason, missed it. But we are caught up on questions in the chat. Okay, hey Lana, recommendations on if the dose 2 folks don't come to the clinic, or Ted?
We would encourage you to make sure you're doing a reminder recall system to make sure they're coming in. If you've reminded them ahead of time, they still don't come in, recall them. If they say we don't want to come in, we're not coming in for the second dose, you can give the second dose as a first dose for somebody else, but you will need to let us know so we can match that up with a second dose for them. We would prefer that no doses go wasted.
And the only caveat there being, so everything Lana just said, folks, is spot on. We always talk about being preemptive. And so what are all of the measures? And Lisa's put this out in the newsletter before. There's a host of things that you can do to minimize the amount of no-shows. However, we realize life happens. The overall guiding principle, never, never, never waste vaccine. If you give a booster as a prime, The problem that generates is there is not a new booster for that prime. And I won't get into a semantic debate, but as Lena said, please reach out to us and let us know the numbers that you are doing that for. We cannot, from the state side, promise that we will be able to match that prime with a booster. We just cannot promise that. What we can do, it's a big state with hundreds of thousands of vaccines out there, right? And so this is not a one-off problem. And so we've been able to solve this very often by shifting vaccine around amongst providers. So if you want to solve that, you have to let us know about the problem. So please do not withhold. Thank you. And Lisa, if it's okay, I got a private message, which I think is applicable to everybody. And the question is, where is the unvaccinated eligible population coming from? And that is coming from Deloitte's work with our vaccine analysis. So without getting too into the weeds, all vaccinations that are occurring in Missouri are being reported back. And if you haven't seen our dashboard, really encourage you to go to our website and to see that. And Lisa will drop that into the chat. And so we are looking at total eligible population. We have for those individuals that are being vaccinated, where they reside. And so we are able to see by region how many folks have received a vaccination. Deloitte has a data set that is about 20 years old now, and it's not 20 years out of date. It is 20 years old of building and refreshing on a daily basis. And so they have a pretty accurate understanding of how many total eligible people are within each region. And so we compare those two. Again, it's always going to be imprecise. However, it is more precise to do unvaccinated eligible populations than just general population, especially when the vaccine is currently still not eligible for those 0 to 18. So nothing is going to be perfect. We are looking for the second best solution. And we believe using data to the best of our abilities to direct vaccine is the most appropriate way to serve Missourians.
I do see, this is Lana, I do see a question on insurance in the chat box. We can reach out to CDC. I know the what is it called? I can't remember. The immunization IV Summit partners have been working on a bunch of adult material, especially as it regards billing. I can see if they have anything to help with processing insurance claims. I'm sure if they do, I will give it to Lisa so she can post it for everybody.
And Lisa, it looks like we may have dropped the wrong link in. Folks, we'll drop some of those links. We'll drop all of the links. So I'm looking at Immute. I just tried the links above and under Janssen recipient. They're not. We will drop Janssen's fact sheet in there for everybody.
Yes, my apologies. I thought that was fixed earlier today, and it looks like it wasn't yet. So I did post a couple links that will get you to the right place, though. The news release there, at the bottom of the news release, there are fact sheets for both providers and recipients. The standing order is also directly within that as well. And then a direct link to the standing order has been posted, but I will make sure to get that fixed this afternoon.
And Lisa, do you see that question from Miranda Phillips? I don't have that in my repertoire to answer. However, Lana might.
Yeah, that was, I think I will check, Miranda, with the National Adult Immunization Summit people. It is a national organization. They do work on these items for insurance and making sure pharmacies can vaccinate with private insurers. So I'll see if what they have and share it with Lisa so that she can get it out to everybody. And also on long-term care facilities. Yes. So Walgreens and CVS are administering first doses at their last clinics if requested. We're looking at a plan on how to get those people, those that get vaccinated at that clinic, how to get their second dose. As soon as we review it and we get approval, we will share that with everybody.
And Lisa, it may be helpful to directly address Ellen's concern. She says that we are wanting to hold a large-scale community event and just get the vaccine once a month at a minimum. How can we communicate that so this is considered for our situation? So a couple of points here. One is that the regional implementation teams, and we're happy to drop who those are for each region, help funnel some of those requests. And we realize Ellen and everyone else that is submitting through the all other community providers, as you can see there, 5,500 does not go a long way. And that's because we're trying to use that those vaccines as well as possible in those other distribution channels. So Ellen, one possibility is to reach out to your regional implementation team and ask about that. Another one is to continue to submit for all other community providers. And additionally, we encourage, as you can see here, FQHCs and LPHAs, and even possibly your high throughput healthcares, reaching out to them. And we're happy to provide liaisons for each of those to discuss with them about how you can partner for events. The short answer that will make no one happy is that there's a constrained amount of supply. And so we can't give you certainty when we don't have that certainty.
Some other questions in there, Ted, about when we'll know the allocations for the later half of March as far as high throughput health center allocations.
Yep. So by next week, we will have a estimate of how all of these, what you see on the slide will change. And we're going to be reaching out to each distribution channel and having those discussions. So next week, if you do not have a meeting by Wednesday, please reach out. So high throughput healthcare, we will meet with using our relationship with MHA, FQHCs through Joe Purley, and LPHAs through Larry, and then pharmacies will be through the Missouri Pharmacy Association. And we will also show those changes here in this as well.
And everybody, I did post a link. CDC had a clinician outreach call this morning or this afternoon at 1 o'clock on Janssen, the Janssen vaccine, J&J. And so I posted the link for you to look at. They usually post the slides after the call.
Thanks, Lana. And there was a question about Janssen training on TCEO. She said she tried the link earlier today and it didn't work. Are you familiar with that?
No, I am not.
Okay.
I'll look it up and see what I can find.
In Lisa, I believe DH is asking in Region F, one group receives 4,000 doses 1 week and another receives 2,000. She's referring to high throughput healthcare. And yes, you can expect for the week of March 8th and the week of March 15th for that to continue.
Okay, thank you. And Andrea is asking when the next tier opens up. I'm sure we will still be working on our current eligible residents. Should we continue to prioritize them? We will not have the vaccine supply to start the next tier right away. And I don't know if Adam, are you with us? He said he may be juggling right now. I mean, I know from
Lisa, I heard you, but I could not catch the first part of your question.
Sure.
I heard it related to the tiers.
Yeah. So as we're working to, toward closer to the March 15th next tier opening, Andrea is asking if we should continue to prioritize the eligible residents who are currently eligible with like tier 2 and above, since they won't have the vaccine supply to start tier 3 right away.
Excellent question. I think that's one of the most salient and relevant that we've got out there right now. So from a state level, one of the things that we have to really do is look at both the supply side and the demand side as we are working through those decisions on dealing with opening the tiers. And because we are taking a statewide approach to that, we know that in some counties, they may exhaust all of the 1A and 1B1 and 2 populations before other counties have gotten all the way through the 1A population. And so what we think is important is making sure that that statewide balance is maintained. And we have to operate that way from the standpoint of it's a state plan that was approved by the federal authority, and we have to operate it as a state. So we do recognize that there's going to be some differences across the state, and with that, different strategies on how those implementations may occur. If communities are looking to prioritize or focus, we would ask that they make sure that they're doing so not exclusively of individuals outside of their prioritized populations. So, for example, we don't want to be in a circumstance where you as a county make the determination that you're not moving into the 1B3 population. We certainly understand that you want to continue to prioritize doing the 1B1 and 1B2, but we also know that you need to be moving into that other population as well. And some of the guesswork that I think your communities have to work through is what sort of allocations you need versus the actual uptake demand that will be in place. And so that's why we've kind of established this approach. We know that, yes, there will be some need to continue to focus on some of those upper tier priorities, but we also don't want to do it at the exclusion of others. So we recognize that that balance has to be maintained. So will there be events or groups that you work with that are probably in some of those upper tiers and do events specific to them? I'm sure that will be the case, but we also want to make sure that you are getting quickly into that 1B tier 3 population, because as the supply continues to ramp up, we are going to soon see an inversion in the demand versus supply challenge. And when that happens, you will see a lot more supply available than what the demand is calling for. And so you need to have been working through all of those different tiers, not just trying to stick with one at a time. And so I hope that provides some level of clarity as to our thought process as to what we're trying to get you to.
Adam, and Cape County is asking about the data on the percentages of the eligible population that is unvaccinated. Will that data be made available to vaccinators?
So we are working on trying to get to that point, and once we have the ability to share that data, we will certainly continue, especially in our local public health agencies. Part of our objective there is to make sure that as we are moving forward, you all are looped in with the same information and data that we have at DHSS. So we'll continue to work on that front in the public health world, knowing that as we move in those tiers, we do want to give you that data and share very transparently about what you're doing in your population and how you've been impactful already.
And Leah has some facilities that have not been serviced yet, some long-term care facilities and independent style living, mental health, intellectual disability. Lana, I don't know if you're or Adam, feel free to chime in on what they should do to get connected to have those facilities served.
So one thing I would say there is I suspect some of those may be unlicensed facilities that are not necessarily regulated under the state jurisdiction. And that's one of the bigger groups that we've been seeing that have not yet been in that realm. Then in some of the group home settings, we also are working on an outreach plan for how to go about that in collaboration with the area agencies on aging. We're still working through the details on that piece, but we are making progress. But if you have some specific facilities, excuse me, that you are aware of that have not been enrolled or engaged in that process, feel free to share those back to us at DHSS so that we can at least understand exactly where they fit into the big scheme, so we can give you a good response on that. And then we'll also try and figure out how to help you get them into the pipeline.
Great, thank you. I think we are caught up on questions again, unless there are more that come in the next couple minutes. While we're waiting to see if there are any more questions here for us today, I do want to remind everyone that we do have the vaccinator resource page available. So if you go to mostopscovid.com/vaccinators, there is a resource page. You go to vaccinator resources, and we have towards the bottom of that page loaded a lot of the frequently asked questions from vaccinators right there on the bottom of that page, along with Missouri Vaccine Navigator demos and fact sheets about how to use that system if you're interested, and plenty more other resources as well. We got a message, a private message that may be helpful for everyone. How can phlebotomists be added to the standing orders? Adam, did you want to address that?
Yeah, we can take a look at that. If you would, whoever posed that message, have Lisa reach out to me, or feel free to reach out to me directly, and we can have that conversation. I know that has to go through the process of Dr. Williams' review, and we go through a legal review based on the actual training components that are established in state law. So we can look at that piece and get more information back to you.
Oh, and thanks to Ms. Kathy for bringing in some information about that training link that was mentioned earlier. So there's an update on that in the chat. And I did post a link earlier. It's also on the resource page that I mentioned, but we had our latest newsletter go out to vaccinators on Sunday night, right after the standing order was first issued for the Janssen vaccine. So just a reminder, that newsletter goes out about once a week with any pertinent updates. Please let me know. My email address is in the chat. If you're not on that list and need to be, or have colleagues that would like to be, just please let me know and we can get them added. And again, the webinar, we hope to have a new link for next week that you'll be able to use as long as we are doing these webinars. So look for that in the newsletter that will go out next weekend, or this coming weekend. I'm not seeing any more questions come in. So with that, we'll go ahead and give you 5 minutes back of your day. And everybody have a wonderful day, wonderful week, and we thank you for all you do. Have a good one.